Welcome, and thank you for joining us today for the ACC's Middle East 2020 webinar series. This marks our fourth in the series, this webinar series, which, and obviously our lives have really been turned over with this whole COVID thing. We were originally planning on having a live Middle East conference, but obviously that was postponed. So therefore we evolved into this webinar series, and this, as I said, is our fourth in the series. I believe that Dr. Sobi will be sharing some data about this series with you. Today's webinar includes management of patients with stable coronary disease and management of pulmonary hypertension in the current era. While I wish we could all be together today, obviously the world has different plans for us. So on behalf of the ACC, I appreciate the time you're taking out of your busy schedule to be part of this virtual meeting. So central to ACC's strategic plan is the propagation of actionable knowledge, a concept that places emphasis on making clinical information easier to understand and integrate into your clinical setting. This webinar will hopefully, with its interactive discussion, is central to the purpose and vision that we had. Like our previous webinars, I think engagement is very important. So I encourage all of you listening to ask questions and engage in the discussion after the talks. Before I close, I want to thank the planning committee that included Dr. Sobi and Dr. Magdi Abdelmahed and our faculty today. A huge thank you as well to the ACC staff involved in bringing this virtual meeting to life. Last but not least, thank you again for joining us in these uncertain times. Each of you represents a diverse collection of expertise. Your perspectives are incredibly important to the mission of this webinar, and I really look forward to a robust discussion today. Now I want to introduce my friend, my colleague, my co-chair, Dr. Mohammed Sobi. Dr. Sobi, take it away.
Okay, thank you, Deputy. Just the screen. I'm sharing that now. Okay. Thanks. I'm sorry for delay because of just the time lag between Egypt and United States. Let's start this ECC and Egypt chapter boards. Actually, Deputy, the chair of the ACC Middle East Conference, Dr. Magdi Abdelmahed, immediate past president of Egyptian Strategic Cardiology, myself as the ACC Egypt chapter governor, CV rep president, and steering committee of the ACC Middle East and Africa. Actually, the project overview, as Dr. Deputy said, that we have postponed the ECC 2020 to 2021 in October. And because of this, we decided to make an actual webinars, and this is the virtual events. It was very successful online meetings. Our shared commitment transforming cardiovascular care, ECC and ECC chapter to deliver an engaging forum to critically examine evidence-based strategies, contemporary best practice, and clinical decision-making to reach our common objective, improving heart health of patient cardiovascular disease. The project objective should be global experts with the local learning, practical solutions, and finally creating connections. We have four waves, decided to have four waves. Wave one was main topics: managing complex patient acute coronary syndromes, heart failure, established and emerging therapy. Actually, the statistics of this was 441 viewers, 2 sessions, 4 topics, 8 experts, 2 symposium, and about 36 countries involving on this ACC Middle East. The wave 2 main topics was contemporary therapies for hypertension, dyslipidemia, therapeutic option treatment AF, and it was 508 viewers, 2 sessions, 4 topics, 8 experts. It's about 34 attendee of the countries, 34 countries attending this. And then wave 3, the last one, was contemporary management aortic disease from imaging to interventions. And then this from imaging to intervention was very successful as well, with 492 viewers, 1 session, long session, 3 topics and 8 experts at the same number, about 36 countries involving this. Today we have wave 4, the final wave 4, the management of patients with stable coronary disease and the management of pulmonary hypertension current era is 2 sessions, 5 topics, 12 experts. As you can see that the first session moderator is Deputy Dr. Ramzi Nwad, Dr. Garsankiwan, I think they will join. The case presentation by Dr. Haitham Suleiman from Egypt, Khalid Ziada, United States. Actually, Dr. Khalid now is coming the leader of the international aspects of the regarding this ACC Middle East next year, and also the debate between also Dr. Khalid Ziadan and Dr. Mohammed Kordi, which is the president of the SAGIC, which intervention group in Saudi Arabia. And then the second session will be by Dr. Bakeman, Dr. Magdi Al-Hamid, Dr. Ahmed Abaati about pulmonary hypertension, which is current data nowadays, very important pulmonary hypertension, as you can see in different conferences, what you're going to see. Dr. Karim Saeed from Egypt in Cairo University, and then Dr. Sadershan, USA. It's a competition. It's not competition. It's a management. This includes risk stratification, diagnosis, updating, and finally we close with deputy. I hope that you have a lot of questions inside this one, and I hope that we can succeed. We succeeded in doing this webinar for you. Now, save this date, please, and stay tuned. Next year we have ACC Middle East 2021 in Cairo, again, Egypt, in the same place, October 14, 15, but pre-conference October 13. We are now starting to have, be 1st of December, we have the group to have preparing for you the planning committee will try to have a very good program in these 3 days. Finally, thanks to our sponsor Sanofi. At the end, I will have a lecture regarding this Sanofi about the Odyssey, and also organized by ICOM company. And thanks for ECC and ICOM company for preparation and technical support. And thank you very much. I hope you will enjoy in 1.5 hours this webinar. Thank you. Now I leave the mic to Dr. Dibity. You will moderate this session.
Okay, so I think our first up is Dr. Salman giving us a case presentation.
Thank you, Dr. Dibity, and thank you, Dr. Mohammed Sobhi, to having me the honor to present this introductory case about multivessel disease with chronic coronary syndrome. So we have a 55-year-old male, type 2 diabetes, smoker. He's having a typical chest pain for the past 4 years, despite medical treatment that started only in the past year. The pain evolved from walking 3 blocks to have the chest pain, the second and third year, 2 blocks, and in the 4th year, he's having the chest pain in less than 1 block. Upon examination, his blood pressure was 136/84, heart rate was 80 beats per minute, body mass index is 25, and EKG had unremarkable changes apart from left atrial abnormalities. When we performed echocardiography, the ejection fraction was 40% with grade 1 diastolic dysfunction, trivial mitral regurg, and no regional motion abnormalities, but the patient had global hypokinesia. His medical treatment confirmed from metformin 1 gram for diabetes, with hemoglobin A1C 7.8, metoprolol 50 milligram, 100 milligram, nitroglycerin as isosorbide mononitrate 50 milligram per day, atorvastatin 40 milligram with an LDL of 70 milligram per deciliter, and he is reporting frequent use of sublingual nitroglycerin to perform his daily activities. So, despite this medical treatment, he still have angina. So, what's the next step? If we have an invisible camera, this will be the picture of the doctor fighting himself between, this is an obvious case, let's go to invasive strategy or invasive tests, and the commitment to go by the algorithms of the guidelines. And if we go to the algorithms, this is a typical chest pain. We consider comorbidities of the patient and quality of life. The patient cannot live a normal life. He has depressed left ventricular functions. So the next step is to go to the pretest probability and the clinical likelihood of the patient. And for our patient, the pre-test probability is very high, 32% for his age group. And for the clinical likelihood or the clinical risk factors added to coronary artery disease, he has plenty of them. Is dyslipidemic, diabetic, hypertensive, smoker, and has depressed left ventricular functions. And in the American guidelines, this patient is considered a high-risk patient, noting that his left ventricular ejection fraction is below 45%, and he has typical symptoms of angina. So, which should we do a coronary CTA? Should we do an invasive coronary angiography? What to do? In the European guidelines 2019, this patient have every risk factor to prefer invasive coronary angiography with functional assessment of his coronary arteries. He has a high clinical likelihood and severe symptoms. He has typical angina at low exercise level, and he has left ventricular dysfunction suggestive of coronary artery disease. So I think the angel and the demon are now have an agreement to go for invasive angiography. We performed a diagnostic angiography via radial approach. The patient had a nearly subtotal or total proximal circumflex, a significant proximal to mid-LAD lesion with an ostial subtotal occlusion of the diagonal branch. There was no significant lesions at the ostia of the LAD circumflex or distal left main disease. And the right coronary had a borderline lesion at mid part. So this lesion was subjected to an IFR that surprisingly was significant. The IFR was 0.83. So now we are facing a patient with chronic coronary syndrome and 3-vessel disease. And to make the picture more clear, we calculated the syntax score of this patient, and the syntax score turned out to be 28.5. So the big question that we are facing today, whether we go to medical treatment or for intervention. And this what we will find out in the next debate, and thank you so much.
Great, thank you so much. That was a very interesting case. I think Dr. Ziadi is going to talk to us about, give us hopefully some answers so that we can answer what the next best step is in this case. So Khalid?
Yes. Can you hear me?
Yes.
And can you see my slide?
Yes, clearly.
Okay, great. So thank you, Haitham. Thank you, Dr. Mohammed Sobhi and Dipti for inviting me. This is a tough case. I'll start by saying I'm an interventionalist, but I was given the task to say that medical therapy is better. And so I did my best. So I think here, I generally don't like the idea of one therapy better or the other therapy less. I prefer to say something like medical therapy sort of give it a chance at the beginning of the management, or should be the beginning management of most patients. Let's break down this case a little bit. So this is a 55-year-old man with 3-vessel coronary disease and class 3 angina. I think it's relatively stable, although it has progressed over a long time. He does have a reduced ejection fraction. His diabetes is not well controlled based on the hemoglobin A1C. His blood pressure is not controlled based on the SPRINT criteria and the guidelines for diabetics. His heart rate is still 80. And I don't know, Haitham did not mention other comorbidities like CKD or other things, but let's put that aside for a little bit. So what are the goals of therapy? Whenever we see a patient and we're trying to treat them, we have two objectives. One is to reduce future adverse events and mortality, and two is to improve quality of life. So this man has both at risk. He is at risk of having future events, no question about it. He's also not having a great quality of life with progressive angina. So we need to address both. And how would we do that? Well, we have three options. And we don't have to use one or the other. We can use multiple options at the same time. So let me start by the big elephant in the room, which is the Ischemia trial. What the Ischemia trial did is that it looked at 5,000 patients with stable coronary disease. They had moderate to severe ischemia using stress testing. We didn't do a stress test in this patient, but I think we all would agree that he has moderate to severe ischemia, given the anatomic stratification that was used. These patients were randomized to conservative versus invasive strategies, and they were followed for 3 years. And I show you this table. You don't have to look at the whole table, but just see that the diabetics in this study were 41%. So a very good representation of diabetic patients. So our patient fits pretty nicely in the ischemia trial population. They looked at the composite endpoint of death, MI, cardiac arrest, and hospitalization for angina or heart failure. And they followed the patients, as I said, for 3 years. And the conclusion was that there really is no superiority of the invasive strategy. Conservatively managed patients did just as well as far as mortality, as far as the myocardial infarction, and as far as hospitalization. There was a little bit of extra myocardial infarctions early on with the invasive strategy, probably peri-procedural MIs, and there was a less incidence of myocardial infarctions in the invasive patients later on. There was about a 20% in the conservative strategy that underwent coronary angiography, so those were kind of treated invasively. But when we went by the intention to treat, there really was no statistically significant difference between the groups. And if you look at the subgroup analysis here, all patients were about the same. No subgroup looked like it was specifically benefiting from one strategy or the other. So Ischemia trial basically is telling us that medical therapy works here in this patient, even if they have moderate to severe ischemia, and that they will do just as well whether we treat them invasively or we treat them medically. I do want to bring up a couple of points about medical management. I think the term medical management needs to be well defined. In the clinical trials, generally, patients are treated medically in a very aggressive way. So I think if the ischemia trial is redone today, these patients would be managed even better than what they were when the study was conducted, and that was, in the last few years. But even in the last 2 years, we now have much better understanding of management of diabetes and much better tools to manage diabetes, as well as lipid-lowering therapy and other things. So, for example, this is the EMPA-REG outcome trial that looked at empagliflozin versus placebo for the management of diabetics, in addition to all other therapies that they're on. 7,000 patients, 3 years, and they looked at a composite of cardiovascular death, MI, and stroke. So the idea here was to look at cardiovascular outcomes in diabetics using these SGLT2 inhibitor class of drugs. And here are the results. There was a dramatic reduction in cardiovascular death that you see on the lower graphic there, and in the composite endpoint as well. This study is basically groundbreaking. We have a drug now that we can use in diabetics that reduces cardiovascular death by 40%. That's incredible. All subgroups did about the same. Empagliflozin was beneficial in all subgroups. So if we can offer our patient a medication that reduces their mortality by 40%, I think that is something that that patient should be on. I'm sorry, it's going backwards. So this is an important tool that we have and that has not been used in this patient. Now, let's look at the lipid-lowering therapy. Just to remind you of the ASTEROID trial, this was a trial that looked at rosuvastatin using IBIS criteria for measurement of plaque regression or progression. It's a small study, but it did show something interesting. When the LDL was reduced to 60 milligrams per deciliter using 40 milligrams of rosuvastatin, we saw a reduction in plaque size, in atheroma volume. And I don't mean to say that these lesions that this patient has are going to go away if we put them on high dose or high potency statin. But I do want to say that high potency statins are very effective. And this study was not powered to detect clinical outcomes, but IMPROVE-IT did do that. IMPROVE-IT looked at 18,000 patients. They were randomized to simvastatin versus simvastatin plus ezetimibe. And I only bring up IMPROVE-IT because in the combination group, the LDL was reduced down to the 50s, 53 milligrams per deciliter. And they were followed for 6 years. And again, a statistically significant reduction in the composite endpoint of adverse cardiovascular outcomes. Pretty significant reduction. You don't see it early. It takes about 2 years. But when the curves separate, you see a significant reduction in cardiovascular adverse events. So again, we can offer this patient more aggressive lipid-lowering therapy that can improve their outcome, reducing their events. We didn't mention ACE inhibitors and angiotensin receptor blockers for this patient for renal protection. I think that's important as well. I think the patient's blood pressure needs more aggressive control. Based on the SPRINT guidelines, his blood pressure should be under 120 over and under 70. I think he needs more effective beta blockade with a heart rate in the 50s to reduce his myocardial oxygen demand. We can escalate his isosorbide mononitrate. We can add a calcium channel blocker. We can add renosine. We have a lot of anti-anginals that we haven't used yet for this patient. Whether he would benefit from dual antiplatelet therapy is somewhat debatable, although charisma can say, for example, may show some benefit in reducing myocardial infarctions at a risk of increased bleeding. Smoking cessation obviously is critical for this patient as well. So I think there's a lot of tools here that we can use to improve the patient's not just hard endpoint adverse events, but also quality of life. I will be honest, and again, as I said, I don't think that we should use these different approaches as competitive, but more as complementary. There are two features in this individual patient that are very important not to miss. One is he has impaired left ventricular function. The second is that his angina has been progressive. So I think that's really important. And these are indications for revascularization in the guidelines. So we don't need to miss that. But I think in addition to that, I think we need to also start by agreeing that his medical therapy can be improved on. I'm going to stop here. I have some more comments to make, but I'll wait for Dr. Kurdi to make his case. Thank you very much.
So Dr. Kurdi, let's hear from you about not medical therapy, but I think invasive therapy and your argument for that.
Sure. First, I think you need to stop sharing because I can't share.
Yeah, I'm trying to see how to do that. Yeah.
Thank you.
That's good there.
First of all, thank you for inviting me, and thanks for giving me the easiest task. I think Dr. Khalid took the tough one. Selling this to a medical therapy alone is actually a big challenge. But I think we all, and I enjoyed how Dr. Khalid put the facts, trying to defend the medical therapy, but we all do the medical therapy, and we know that there is no single option. There is always a combination of different different therapy. Optimal medical therapy is part of the therapy, whatever you're going to do, to send him to surgery, or even if you go for angioplasty. The facts that we have for this case, that we always, as we look into any index patient for any choices, we have to look at what's the patient's story. And I think our patient is a young patient. He's a 55 years old. He's quite young. And based on the WHO classification, he's actually young. And so he still have about another 30 years to go on optimal medical therapy if that was the choice. So I wouldn't actually think that would be something that he will enjoy. He's quite symptomatic, and he's failing lots of, he went through over years of his progressive angina, and he was using frequent sublingual nitrate in spite of a reasonable medical therapy. His heart rate in the 80s, I agree, his blood pressure 130, but it's not like 160 or you're seeing a heart rate in the 90s. He's reasonably medicated with a beta blocker and as well as statin, 40 milligrams, atorvastatin. So he's well medicated. I mean, not really, but he is reasonably medicated. He's now having an ischemic cardiomyopathy, so that has to be considered. The other thing which you review in his angiogram, he really doesn't have an aggressive, diffuse disease where you think medical, where we see in the Middle East, where you see diffuse disease. He has really a nice focal lesion in the circ, another lesion in the LAD, and a focal lesion with the IFR that was done in the RCA. So his chance of actually restenosis with proper and new stents is very small, and most likely he will do very well. The other thing, of course, his syntax score is less than 30, which also gives him a favor that he's not a surgical candidate. Exactly as Dr. Khalid stated, when we think about patient and what are the options we're going to do for him, I mean, we really do things because we want to reduce mortalities, either all-cause mortality or cardiac. We need to relieve symptoms and improve the quality of life. And also, as you think always, you want to do something which is cost-effective because you're a member and part of the healthcare system, and you don't want to actually have a huge burden on the healthcare system by adding more and more and more medications and creating more cost. So we have to look at the literature and see what is published. And we look at the literature about medical therapy versus BCI. Really, it's a mixed bag of different inclusion-exclusion criteria. And you need to understand the limitation always of each one. There's multiple meta-analysis. One of the things that, one of the meta-analysis which looked at is by Dr. Bersani, published in Circulation, and looked at the PubMed, IMBAS, and Cochrane database, tried to collect these studies and try to screen them out and try to come up with some result to indicate which way we should go, comparing medical therapy versus PCI. And if you look at this, which is maybe a little bit difficult, but you look over the years and look at all the options, and you see that medical therapy actually perform well. There is maybe a tendency in some toward the PCI, but there is no significant difference between medical therapy, optimal medical therapy versus PCI. And this comes because the data actually comes from different generations, different stents, and different stages of development in interventional cardiology, with more moving into radial, less complication, optimizing the scaffold and proper intracoronary imaging. All that kind of things was not included in a lot of these trials. The risk of cardiac death also in this meta-analysis indicate, you can see that there is the COURAGE trial, DEFER, the Japanese data, MAS1, MAS2, RITA2, and the Berry 2D as well, which is a little bit older data, but at the end of the day, maybe it's favored some favor a little bit in favor of PCI, but not really a significant difference that make you say that PCI is better than medical therapy. When the non-fatal MI is also, there is no difference. So when you come to mortality, all-cause mortality, non-fatal MI, in fact, there is no solid data that will make me say that PCI is better than medical therapy. The thing that we always going to hang our excuses why you want to do the PCI is symptoms relief. And honestly, symptom relief is a significant thing. I mean, a significant improvement in the symptoms mean the patient life and the quality of life is changing. I can't imagine this patient walking one block and having spraying his under his tongue because every time he does this one block walking, he's going to have the chest pain. It's a miserable life, and it's going to make a lot of difference in his life, in the quality of life. And this is exactly what this meta-analysis looked. Yeah, there is a significant difference of favoring less symptoms, less angina, and more angina relief by doing PCI. And all these studies using this meta-analysis. If you go to the COURAGE trial as well, it's the same thing. There is a freedom from angina was significantly better with BCI. So really, quality of life, which is basically their general health, the rest, the free from pain, social functioning, everything improved by BCI, which is a significant indicator and a very important for the patient. We sometimes downplay that there's only improvement in symptoms. No, symptoms are very important because this is a quality of life. This is why we're doctors. We need to intervene and improve patient quality of life. Yes, we wish we can reduce their mortality as well, but one of the important things that we should do is improve the quality of life of our patients. And BCI does. When we look at the ischemia is not applicable here because this patient is one of the exclusion criteria because he does have intractable angina and having recurrent angina, and this is one of the exclusion criteria for the ischemia trial. So I actually think the ischemia does not apply to our patient today. So I wouldn't go and discuss ischemia, although Dr. Khalid did a great discussion review of the ischemia trial. But yes, he has most likely large burden of ischemia with a significant reduction in LV function. But as well, he was excluded from the beginning because he's one of the exclusion criteria of having recurrent and intractable angina in spite of having good dose of nitro. A cost effectiveness of BCI, I think there are several cost analyses show that BCI in chronic angina is effective over the optimal medical therapy. 30% of the studies indicate that there's a crossover from the medical arm to the BCI. And in the registries, about almost 60%, they move over the time, over the years to getting BCI. So I think in my opinion, and I try to be as short as possible because I want to enjoy the discussion, PCI is the option for this patient. I think even Dr. Khalid believes so because I enjoyed his last slide when he's saying, yes, this patient had a clear indication for going for a PCI. Balancing all the facts together and trying to do the best service for our patient, I think we should send them for PCI. Thank you.
Thank you, Dr. Kurdi. So this was a great case, and I enjoyed the presentation. I believe my co-moderator, Dr. Kivan, is also on. So there he is. So I'll start off with the first question. So do you think, I think that most of us agree that an interventional strategy is what you're going to have to do. I do think there was room for medical therapy, and I think that Khalid, you did a great job of presenting that. Clearly, maybe a higher dose of statins. I agree with maybe thinking about EMPA in terms of the diabetes management, certainly more beta blockade. Even with the LV dysfunction, we didn't have an ACE inhibitor on board. So there's a lot of other things we can do for medical therapy. But let me ask both of you, in terms of interventional, PCI versus CABG. It's a diabetic patient, LV dysfunction, granted the syntax score is less than 30. So talk to me about how you decide between PCI and CABG in this patient if you decide to go down the interventional arm.
Dr. Muhammad, do you want to start?
Whatever you were.
Go ahead.
Yeah. I mean, for us here, there are multiple factors that we have to put together. I think number one, and this is what I always say, you have to know your center numbers and what are the outcome in your center. Because if you're talking about US and the number in US, it's maybe not true in a lot of centers in the Middle East. So you have really to look and compare what's literature saying versus what you have to make a decision in favor of your patients. That's number one for me. Number two, I think this patient is actually having a low syntax score, so he's more in favor of PCI. It's very focal, it's not complex, there's no significant calcification. I think it's a straightforward, there is no straightforward BCI, but I think this is a straightforward BCI, and the patient can go back to his life. His diabetes is not terribly uncontrolled. I know ideally you want it less than 7, let's talk about Middle East. He's really one of these guys that, and he's young, he's 55. We can always send him to surgery down the road, but I don't think we will.
Let me ask you before Khalid weighs in. When you do PCI, talk to me about strategy. Would you do would you do one vessel at a time? Would you do 2 vessels? Would you do it all revascularization all at the same time?
Is it for me?
Yes.
Oh yeah, I think we will do it all together in one setup, because it's all. The IFR has shown that the RCA is significant. I think he doesn't have any kidney disease. He's a young man. I think I'll do it all together.
Okay. So Khalid, I'm going to ask you the same question.
Yeah, I would actually probably for me, I would send this patient to surgery. Can I share my screen? I'll show you one slide.
Yes.
So I think the biggest study that guides the treatment of diabetics with multivessel disease is Freedom. And this is Freedom here showing that over 5 years, CABG patients do better than PCI. So, as far as a composite endpoint, especially with myocardial infarction, mortality was better, but not that much. So myocardial infarction is the primary reason why CABG is better, because patients with PCI, diabetics will have more MIs going forward after the first year. But this is a sub-analysis that was done maybe 5 years later or so after the study was done. And I thought that was really interesting. So this is the patients broken down by syntax score. And so then this is the event rates. And you see as time passes, event rates are going up as you expect. The top 3 lines are the surgery patients. And each line represents one group of syntax scores. So high, low, and high, intermediate, and low. And then the bottom 3 lines are PCI. So the only time, there is a surgery group that is a little bit close to the PCI is the low syntax, the opposite. The low syntax patients undergoing PCI will have, slightly lower events. But if you look really, the bottom 3 lines were surgery. With surgery, you see 2 things. One is they're really lower event rates compared to PCI, no matter what the syntax score is. So with surgery, the syntax score doesn't mean much. They all will end up, getting the same bypasses, and they will all do just as well. And all groups undergoing surgery do better than all groups undergoing PCI. So to me, I think multivessel disease diabetics are better treated with surgery and aggressive medical therapy.
Yeah, and I think that's sort of what my point was with the issue of diabetes. That's what I was angling at, I guess. Yeah. Because I think that our practice has been for the diabetics to err towards CABG versus if this was the same patient, same scenario, but not diabetic, I think, Dr. Kurdi, I probably would lean towards the PCI. I would lean towards the PCI like you suggested. But I think with the diabetic, I think the data sort of, for me, tips over to the other side. I'd love to hear.
Totally agree. I totally agree with that. If this patient wasn't diabetic, he would fall somewhere between the low and intermediate groups, and his outcome with PCI would be great. But I think with diabetes, the problem is that the disease is not necessarily in the lesions, but the disease is in the arteries. And so they will tend to progress, and they will tend to have more events over time. Even if it's not in-stent restenosis, it'll be subsequent myocardial infarctions.
So others, Dr. Kiwan, do you have any comments?
You need to unmute her.
Yeah, I agree with Dr. Kurdi that this is not an ischemia patient, because I'm ischemia man. I'm one of the investigators of ischemia trial. So this patient has severe recurrent angina, and the patients with severe uncontrolled angina were not included in ischemia trial. And it's very important that ischemia trial, the optimal medical treatment. Optimal medical treatment was an important issue, which should be stressed in every visit for the patient, that LDL should be less than 70 milligram per deciliter at that time, not 55. Hemoglobin A1C should be less than 7, and blood pressure should be less than 130/80. So optimal medical treatment was an important and integral part. I think it was responsible for the better outcome with medical treatment, that patients were closely monitored for LDL, hemoglobin A1C, blood pressure. And this explains that the long-term benefit of medical treatment is an important issue in patients with chronic coronary syndrome. But these patients ideally is for revascularization based on the angina, based on ejection fraction 40%, and he needs total revascularization. And I prefer PCI because it is doable lesions. It is type A lesions, which can be done very easily with a small amount of contrast, no risk of contrast nephropathy, and no heart failure. So I know that the outcome of surgery compared with PCI was better according to the interesting study presented by Khalid regarding Freedom study. But I think shared decision-making is very important. And I think patients will prefer PCI based on the risk is minimal in these patients, because it's not a complex lesion, it's not a bifurcation, no left main disease. So PCI is a good option for this patient.
Dr. Kiwan.
Yeah, I'm sorry, I've been a little bit late because I was confused. It was actually notified at 9:30 in my calendar. Anyway, I just finished my walking, and I'm not gonna make. I saw that Dr. Kurdi, the case he presented is Canadian Cardiovascular Society Class 3, if I'm not wrong. So we're talking about diabetic, rather moderately symptomatic patients. Now, what about diabetes with 2 vessel disease? And we know that the threshold of pain of angina is rather high, and most of them, they are either non-symptomatic, asymptomatic, or mildly symptomatic. So what's the role of non-invasive evaluation of these patients for ischemia, stress test, dobutamine echo in case of there is an LV dysfunction, or stress echo, or thallium? Do we still have a role in these patients in diabetes?
Yeah, I think when you see the reduced LV function and 40%, and with a very typical story and very high pretest probability, I think angiogram was really justified. And doing an IFR was really a very wise thing to do. Because to do imaging and before taking to the angiogram, I think that would be, I don't know, I mean, you could do it, but I don't think that's something I would do with somebody with ischemic cardiomyopathy. And I'm thinking really of intervening anyhow. because trying to improve his outcome and reducing his mortality down the road. If you want to test the ischemia because it's global, it's rather than not regional, that's maybe one way of thinking, that you think this is a global ischemia, maybe he had something else and I need to do some imaging like nuclear SPECT scan or whatever. That's one way. But in this case, I think Dr. Haytham did the right thing by taking to the cath lab and shooting his coronaries and also doing the IFR for the RCA, which is a borderline lesion angiographically. Regarding CABG, I think it's very interesting in the Middle East because it's about 80% of our patients who comes to the table are diabetic. And if I'm going to send these people to surgery and they are young and the age of 50, I need to do lots of grafts. I need actually to practice doing lots of PCI for grafts and failure of cabbages, because this is what we've been doing. The expectancy for the graft is 10 years, and he's a 55. I send him now for a cabbage in this age. I know the data very well. But we tailor, as I said in the beginning of my presentation, we tailor our practice based on our setup and based of what's the thing that we feel the best for our patients. And really, when we do the BCI, we know what the literature is saying. I know this is a focal lesion. If I see a calcified, difficult, and I know this is going to be a tough case in a diabetic, I may actually say, okay, let's send him to surgery. But if I'm going to send everybody with a triple vessel disease, focal lesion, to surgery in the Middle East, we interventional cardiologists are going to be just watching the cabbagers doing their cabbages. And that's it.
Well, I think it's a good point. I also think the LAD was not proximal. I think it was almost mid. You know, I think that would change a little bit of your thought too, based on the data. Dr. Sobhi, you want to say something?
Yeah, I think I agree completely of in practice. Let's go about the ischemia, Barry trial, carriage. You believe in symptoms. Yeah, and practically the symptoms will not be improved except even on the optimal medical treatment. Sometimes there is symptoms. So you have to respect, because this is quality of life. So I need patient preference. I think this is important. Number two, we have to investigate with the amount of ischemia. I believe in carriage, about 10% or less than 10%. This is not evident in ischemia. So we have to analyze the amount of ischemia. Number two, the symptom of the patient and quality of life in order to. But this case is not a straightforward case for debate, because it goes with but sometimes you have an intermediate case, intermediate lesions, one critical and two intermediate lesions in three vessel disease, not in proximal. But this is a classic. But if you have a proximal lesions and critical lesion and symptom class 3, I think this is no way about just do PCR or cabbage, and this is depending on the syntax or the Euroscore that way. So we have to conclude for the audience what be the future guidelines. Deputy, you are in the ACC, are you believing in this? And Khalid also from USA, and how can you manage your patient in USA, and what be the future according to all these trials?
Do you want to make a comment?
Yeah, I think you make good points about, you know, tailoring the management to the environment that you're in. But I love to put stents in, and they pay me to put stents in, and that'd be great. But the reality is there has not been a single subgroup of diabetics that we do better than the surgeons, unfortunately. So my threshold to send diabetic patients to surgery is very low. I know that whatever we do is not going to last very long. So that's one thing. The second thing about medical therapy and resistant angina, I do agree with that this patient has pretty significant angina. The thing that's important is when we put patients on medical therapy, we have to be goal-oriented, meaning that we don't just, check the boxes of the number of drugs that they're on, but we want to actually have an effect. So, if his heart rate is 80, then he's not beta blocked. if his blood pressure isn't, less than 120, then his blood pressure is not controlled. If his hemoglobin A1C is more than 7, then that he's not, controlled. So I mean, you can, before we say that he's resistant to treatment, I think it's important to actually achieve the goals of therapy or the targets, and then say, even though we have all this, he's still having symptoms. And I do agree that with this type of anatomy, he's probably going to continue to have symptoms. But I just don't think that we tried hard enough, is what I was trying to say.
And I agree with that. I think that if you're a purist, you would say that the patient was not there wasn't maximal medical therapy prior to doing the angiogram. So I think you make a really good point about that. I do think the patient could have been better beta blocked, blood pressure better controlled, diabetes better controlled, probably a higher dose statin. So, I mean, there are a few more things you can do before, but I agree, given the anatomy, probably the patient would have continued to have chest pain. But if you were to really follow the guidelines, you would say the patient, as Dr. Solman presented it, should have had further medical therapy. Then they continue to have symptoms. Then you would do the angiogram and then go through this. So we didn't really talk all about the medical therapy, but I'd love to talk about the issue of EMPA, because obviously the SGLT2s in heart failure, Magdi, as you know, it's gotten a lot of press, and Beacom can talk about that too. But we're also seeing the data for EMPA and just cardiovascular mortality, reduction. So what's everybody's thought about utilizing these drugs more for our diabetic patients? Are we using them? Yeah, Dr. Sobhi.
Yes, in all patients with heart failure, I'm using now the DAPA. I'm using the DAPA heart failure. Already the EMPA is for Boehringer, so it's not so popular. It's not coming at the original now, just on a generic. So I'm starting with the original with AstraZeneca for Sega now for all patient heart failure. Very successful. But after taking ARNI, I'm not taking just the beginning of heart failure. But in ischemic patients, no. But just patients with left ventricular dysfunction and reduced ejection fraction, I'm using the DAPA according to DAPA heart failure. I think is the EMPA and DAPA approved the FDA non-heart failure as well. So that's why we go there to these patients at the fifth pillar.
Well, the EMPA reduced data was good for EMPA, also for heart failure. But I mean, yes. So I think EMPA does have heart failure indication also. I guess my question was more global about using EMPA in these cardiovascular patients. I mean, it almost seems like when we see these patients with coronary disease, and given the data that Khalid had presented, I think we should be thinking about those drugs even in our coronary artery disease patients. I mean, we're definitely thinking about it for our heart failure patients as one of the 4 pillars. As Greg Fonner had that saying, that said ARNI, our the drug, mineralocorticoid, and then our beta blockers, but the 4th would be the SGLT2. So Beacom, you're on. Maybe you can make a comment about that.
Sure. 2 concepts. One is the role of SGLT2 inhibitors in patients with either established cardiovascular disease or with cardiovascular risk factors. And in 5 studies, SGLT2 inhibitors actually resulted in reduction in future cardiovascular events, as well as heart failure events. So MACE events go down in patients treated with SGLT2 inhibitors with diabetes and cardiovascular risk. And these included patients with angina, CAD, or risk factors for cardiovascular disease. And these were patients without established heart failure. And one of the most significant reductions in the endpoints was reduction in future development of heart failure. So they're very potent agents for prevention of future cardiovascular events, including heart failure. The second concept is what Dr. Sobhi was referring to, is use of SGLT2 inhibitors in established heart failure patients with reduced EF, regardless of diabetes. And these were the DAPA and the EMPEROR reduce trials demonstrating efficacy of dapagliflozin as well as empagliflozin in patients with reduced EF, specifically EF less than 40 for NYHA class 2 to 4 heart failure patients, resulting in significant reduction in cardiovascular death and heart failure hospitalizations. So prevention in diabetic patients with cardiovascular risk as well as treatment of heart failure patients. Two concepts.
Also, I mean, I think it's really important to say that, you know, there's a relative risk reduction of 40% in cardiovascular death. I mean, there are very few drugs that we have that do that. This is a pretty dramatic effect. So, and these types of patients, diabetics with coronary artery disease, their event rates are high. So, relative reduction here is significant. The question, you know, maybe Dippy, you can comment on that, is this now in the realm of cardiology? Should the cardiologists be prescribing those, or should we be referring our patients to the endocrinologist to do that?
Oh, I think we absolutely are going to have to take ownership of this. You know, initially when I heard about this several years ago, I thought, absolutely not. This is going to break our backs to add one more drug. But I think as the data's come out, I just think that we take ownership of our patients with heart disease. And I think that the endocrinologists are not going to be aggressive enough and step up to the plate for that. We recently had a multidisciplinary discussion with endocrinology and nephrology about this. The nephrologists are much more on board. The endocrinologists are a little bit more timid. One of the endocrinologists made a comment, it's difficult for us to tell the difference between systolic, you know, the HFrEF and HFpEF. You know, so you're like, okay, if they're at this basic level, it's going to be a little bit more difficult. So I do think that we're going to be taking ownership. So I'm being very aggressive about pushing them for putting these patients on these drugs. And if they're heart failure, I'm just taking charge of putting these patients on them.
I agree. I think this is going to be a tool for the cardiologist, not necessarily for the primary care doctor or the endocrinologist. I agree.
Yeah, and I think the company recognizing they're starting to market to us. So
I fully agree. Unfortunately, we've seen few patients deteriorating their heart failure when they are taken in charge, with all due respect, by endocrinologists because of probably non-aggressivity and not too much knowledge about the LV function and the value of low ejection fraction. I fully agree. What I suggest is maybe keep endocrinologists on board for a better control of the diabetes, but in the same time, coordinate with him the introduction of these medications in view of improving or preserving or helping preserve the ejection fraction of or improving it and diminishing or decreasing the risk of events with the future. I think cardiologists are more aggressive in this situation.
I think we're a little bit more timid in the coronary disease realm, and I think that that's where we're sort of trying to get our endocrinology colleagues to come on board and say, hey, if not SGLT2s, how about the GLPs? You know, but they need to be starting to think about drugs that have more cardiovascular benefits.
Make strong suggestions kindly and softly to the endocrinologist.
So
now we are referring patients for endocrinologists when he needs insulin. Otherwise, in our daily practice, we are using the SGLT2 inhibitors in our patients. And I agree with you regarding the use of dapagliflozin or empagliflozin according to the positive outcome data of DAPA-HF and the EMPEROR use. And I'm using even in non-diabetic patients with HFrEF, ejection fraction, low function class 2 to 4, this group of drugs, and it works well, and patients are doing well on this group of drugs. So we have to consider the earlier use of this group of drugs based on the outcome of these trials.
I see Dr. Al-Mawardi is on the line. Do you want to make a comment?
Dr. El-Mawardi, Dr. Ramzi, do you have a comment?
Abdelati, and I would like them to go ahead and say a few words.
Yeah, thank you very much, Professor Pekin, for this nice introduction. It's my pleasure to co-chair this session with Professor Pekin, and I think it's a very important session. And also, I'd like to welcome Professor Sudarjan from Duke University. I know him well because we organized a very interesting session 3 months ago regarding management of patients with pulmonary hypertension, and it was a very interesting session, and he's one of the experts in the field of pulmonary hypertension. So I'd like to welcome him again. And also I'd like to welcome Professor Karim Saeed, the Professor of Cardiology at Cairo University. And allow me, for the sixth time, to introduce the first speaker, Professor Karim Saeed, and he's going to talk about risk stratification for patients with pulmonary hypertension. Dr. Karim. Dr. Ahmed Abdelati, sorry, Dr. Ahmed Abdelati is joining us.
I don't think so.
Dr. Ahmed?
No, I don't think so.
I didn't see him. Okay.
Dr. Saeed, we can't hear you. You may be muted.
Hello, everyone. Can you hear me?
Yes, Karim.
Yes, we can.
First, I want to thank you for this kind invitation, and I hope in the coming 12 minutes to cover a very challenging task discussing the diagnostic methods and approach and risk stratification for patients with pulmonary hypertension. And in this presentation, I'm going to convey 5 messages or 5 stations in the roadmap for the diagnosis and risk stratification of patients with pulmonary hypertension. However, I want to start by stating this fact. Pulmonary hypertension is a trap for late diagnosis and a trap for misdiagnosis as well. And it is estimated that the median average time between pulmonary hypertension symptom onset and the diagnosis is about 3 years. And this rate is constant. It didn't change over the last decade. And almost 3/4 of patients have already advanced pulmonary hypertension on presentation. So I would start by the first station or the first message. We should keep a high index of suspicions for pulmonary hypertension. Pulmonary hypertension has non-specific symptoms. And in order to pick up those patients, we should have a high index of suspicions. Patients coming with unexplained breathlessness or fatigue should be screened for pulmonary hypertension. 85% of those patients would have 1 or 2 of these symptoms. Other symptoms may include chest discomfort, cough, or a manifestation of right-sided heart failure in advanced stages. Also, simple diagnostic tools such as ECG and chest X-ray may give a clue for the presence of right side overload and pulmonary hypertension. And we should screen patients known to be at a high risk for the development of pulmonary hypertension. These include patients with connective tissue disorder, especially patients with systemic sclerosis, patients with family history for pulmonary hypertension, patients with portal hypertension regardless the cause, patients with congenital heart disease with left to right shunt, HIV patients, and patients who used anoxygenic drugs in the past. All those patients should be screened for the presence of pulmonary hypertension. The second message is the fact that echo is not a diagnostic tool for pulmonary hypertension. It is a screening tool. Why? Because this is the definition of pulmonary hypertension. We define pulmonary hypertension as a mean pulmonary artery pressure more than 20 millimeter mercury at rest using right heart catheterization. So it is a hemodynamic definition. And we use the mean pulmonary artery pressure, which is not taken by echo by standard technique. And in this work, we will find that there is a little agreement between pulmonary artery pressure driven by echo Doppler and the pulmonary artery pressure measured directly by heart rate catheterization. And it was found that echo estimates of pulmonary artery systolic pressure was inaccurate in 50% of patients, to the degree that echo may underestimate pulmonary pressure by 34 millimeter mercury and overestimate it by 40 millimeter mercury. So echo has no role for the diagnosis. It is only to assess the probability of pulmonary hypertension. How to assess the probability? First, we measure the tricuspid regurg velocity by Doppler, and we search for echo signs of pulmonary hypertension. We look at the right ventricle, we look to the right ventricular outflow tract and the pulmonary artery, and we look to the right ventricular inflow. This will include the right atrium and the IVC. We have specific signs that may denote the presence of pulmonary hypertension. For example, the presence of dilated right ventricle that has a diameter equal or more than the diameter of the left ventricle. If we have a flattening of the interventricular septum, if we have a dilated right atrium, if we have a dilated pulmonary artery, all of these signs and others give clue to the presence of pulmonary hypertension. Then we look to the findings. If we have a tricuspid regurg velocity more than 3.4 meter per second, this is a high probability for pulmonary hypertension, regardless the presence or absence of indirect sign of pulmonary hypertension by echo. On the other hand, if we have velocity less than 2.8, this excludes the presence of pulmonary hypertension in the majority of cases. And if we have indirect evidence of pulmonary hypertension, the probability will be upgraded into intermediate probability. In those patients with velocities between 2.8 and 3.4, they have intermediate probability. And if they have one or more signs of the indirect pulmonary hypertension by echo, they will be upgraded into a high probability. Patients with intermediate or high probability should undergo further investigations, including even right heart catheterization, while patients with low probability should be investigated for other causes for their breathlessness, for example. On the other, later stages. So this is a summary for the role of echo. It is not as a diagnostic tool. It is a good screening tool. It estimates the probability, and the probability is not defined merely by the presence of a high tricuspid regurgitate velocity. We should combine these with the presence of indirect sign for pulmonary hypertension by echo. The third message is that systematic approach is the key for the diagnosis of pulmonary hypertension. As we know, pulmonary hypertension is classified into 5 groups based upon the pathogenesis and the pathophysiology. Group 1, dealing with pulmonary arterial hypertension. Group 2, pulmonary hypertension due to left heart disease. Group 3, due to lung disease. Group 4, mainly due to chronic thromboembolic pulmonary hypertension. And Group 5, deal with the causes with unclear etiology or with multiple mechanisms. And each of these groups can be subdivided into subgroups. And each subgroup can have many diseases. So, for example, in Group 1, pulmonary arterial hypertension, we have several subgroups such as the heritable, the drug-induced, the associated pulmonary arterial hypertension with connective tissue disease, with HIV and others. And our role is to properly categorize those patients and to detect their phenotype accurately, because this had an impact on the prognosis and on the treatment. How to deal with these dilemma, we follow a well-dedicated algorithm offered by the European Society of Cardiology. And in its initial version, in patients with high or intermediate probability of pulmonary hypertension, we should first rule out or rule in group 2 or group 3 pulmonary hypertension. That's to say, patients with left-sided heart disease or patients with lung disease. Why? For two reasons. First, this is the most common etiology for pulmonary hypertension. Second, they are easily diagnosed using non-invasive tools. And as we can see here, all over the world, between 45 to 50% of causes of pulmonary hypertension is related to the presence of left-sided heart disease. This in bright red. While lung disease may be responsible for 40 to 45% of pulmonary hypertension causes. So all in all, between 80 to 90+% of pulmonary hypertension can be related to either group 2 or group 3. Group 2 with left-sided heart disease have 4 phenotypes. Some are easily diagnosed by the clinical examination and echo, such as presence of congenital heart disease or significant valvular heart disease, or reduced ejection fraction in patients with heart failure. However, patients with heart failure with preserved ejection fraction represents dilemma for the diagnosis. They are common populations. They have modest degree of pulmonary hypertension. They may coexist with other form of pulmonary hypertension. So you should do much effort to properly diagnose those patients with heart failure with preserved ejection fraction, then to categorize and characterize properly their pulmonary hypertension. We have many tools. This was offered by the 6th World Symposium for Pulmonary Hypertension. Patients with metabolic syndrome, elderly populations, those with atrial fibrillations, those with pre-existing known cardiovascular disease may fulfill some criteria for heart failure with preserved ejection fraction. Also, we can use the Heart Failure Association recently proposed algorithm to properly diagnose those patients. Patients in group 3, those patients with lung disease and or hypoxia, also should be subjected to detailed history and respiratory function test, high resolution CT, 6-minute walk test, and importantly, testing for the diffusion capacity of the lung using carbon monoxide. And in post group 2 and 3, we may not be satisfied by the presence of direct relation between pulmonary hypertension and the coexisting disease in some situations, such as the presence of severe pulmonary hypertension. This is not common in patients with HFpEF, for example, or patients with COPD, patients with significant right ventricular dysfunction, patients with disease, especially we should do further investigation to rule out the presence of coexisting etiology for pulmonary hypertension. After ruling out group 2 or 3, we should rule out group 4, which is mainly caused by CTAF, chronic thromboembolic pulmonary hypertension. And the golden diagnostic tool here is a ventilation perfusion scan. Why to do this? Because CTAF is a curable disease in the majority of patients, and after doing pulmonary end arterectomy, those patients had a reasonable good prognosis. 75% survive at 10 years in some series. The second cause is that it is easily overlooked. Many patients may not give a history of prior pulmonary embolism, and also it may coexist with other causes for pulmonary hypertension, such as patients with heart failure with preserved ejection fraction. To the degree that in the recently published 6th World Symposium of Pulmonary Hypertension, ruling out CTAF or group 4 now is a priority, even before going to rule out group 2 or group 3. because it is common, it is easily overlooked, and they may coexist with other phenotypes pulmonary hypertension. When to suspect CTAF? We suspect CTAF in a group of patients those who had splenectomy, prior splenectomy, ventriculoatrial shunts, pacemaker leads, chronic inflammatory disorders, malignant diseases, those who had given thyroid hormone replacement therapy. Only 50% of those patients will give a history of prior pulmonary embolism. And this pulmonary embolism also had some specific features. It occurred at earlier age, showed large perfusion defect in ventilation perfusion scan, and when it is unprovoked. And the standard, as we said, it is a ventilation perfusion scan. It has a sensitivity approaching 100% and specificity between 95 to 100%. And the diagnostic criterion is to detect a large mismatch between the ventilation and perfusion. And after diagnosing CTAF, we should refer these patients to specialized centers to do anatomical characterization of the occluded segment. This can be done by CT pulmonary angiography non-invasively, or in many centers, it is done by direct invasive pulmonary angiography. Many surgeons prefer to do this before the pulmonary endarterectomy. And after ruling out group 2 and group 3 and group 4, we are left with group 1. And here we should refer the patient to right heart catheterization. So we have the diagnostic features of pulmonary arterial hypertension, which is elevated pulmonary artery pressure and low pulmonary artery wedge pressure below 15 millimeter mercury, and elevated pulmonary vascular resistance more than 3 Woods unit. And here we have a long list of diseases that we should exclude. And after excluding all of these diseases, we'll be left with the idiopathic pulmonary arterial hypertension. We should rule out the presence of connective tissue disease, especially systemic sclerosis, HIV infection, portal hypertension, even in absence of obvious liver disease, many congenital heart disease with left to right shunt, and the schistosomiasis, which is common in specific areas. This is a routine lab done to the majority of pulmonary hypertension patients, even before going to the final stage of the algorithm. Usually we ask for iron study, pre-natriuretic peptide, thyroid profile, autoimmune panel, HIV testing, and in Egypt we do schistosomiasis antibodies. The fourth message is to have a very low threshold to do right heart catheterization when it is indicated. Right heart cath is important for the proper diagnosis, the proper phenotyping of pulmonary hypertension, for the risk stratification, to guide the initial therapy and to assess the response, and based upon we can tailor combination therapy afterward. What we do in the right heart cath, we take blood samples for oxygen saturation, and we measure pressures. And based upon this, we can calculate the transpulmonary gradient and the cardiac output, usually with fixed principle, and using those two data, we can calculate the pulmonary vascular resistance. We take a sample from the pulmonary artery and the SVC, and we compare the difference. If it is more than 8%, we suspect the presence of step-up and the presence of left to right shunt. And in this case, we had a run of oximeter taking about 15 samples. We do pulmonary angiography when we suspect CTAF directly to the right and left pulmonary artery. And finally, we do acute vascular activity testing in some group of patients. Those patients are those patients with idiopathic pulmonary arterial hypertension, heritable pulmonary arterial hypertension, or drug-associated pulmonary arterial hypertension, not all patients. And when they can be given calcium channel antagonists. So we can not do this test for patients with hypotension, for example, or in patients with right-sided heart failure. We can use epoprostenol or adenosine or nitric oxide, and a positive response is defined as a decrease in the mean pulmonary artery pressure at least 10 millimeter to absolute level less than 40 millimeter without decrease in the cardiac output. Patients who show vasoreactivity had a very good prognosis, and they have stable hemodynamics, and they can go well, the majority of them, on calcium channel antagonists. However, they are a minority, and those who are not vasoreactive had another form of profile with deterioration and worse prognosis. At the end of right heart catheterization, we can categorize our patients into two groups of patients, those with pre-capillary pulmonary hypertension and those with post-capillary pulmonary hypertension. Pre-capillary is defined as a mean, as we mentioned, more than 20, and wedge pressure less than 15, so we exclude a left side disease, and PVR more than 3 Woods unit. This will include group 1, 3, and 4. While post-capillary pulmonary hypertension, again, patients with mean pressure more than 20, wedge pressure more than 15 here, and PVR less than 3. This is the post-capillary group 2 pulmonary hypertension. And in a group of patients, we will have features of combined pre- and post-capillary pulmonary hypertension, having high pressure, mean pulmonary pressure of the pulmonary artery, and high wedge pressure as well as increase in the PVR more than 3 Woods unit. Despite the importance of right heart cath, it is still underused in many centers, and it is estimated that it is done in 1/3 of patients when it is actually indicated. And there is a misconception that right heart cath is dangerous and unsafe in pulmonary hypertension population, and this misconception has no foundation. In this series of more than 7,000 right heart catheterization, major complication occurred in only 1%, and in majority of them, it was vascular complication with only 4 mortality. The final fifth message is that multimodality approach is important for risk stratification. During this journey, we will collect many data that can categorize our pulmonary hypertension population, mainly pulmonary arterial hypertension, into categories: low risk, high risk, and maybe intermediate risk. And we have many criteria that can we use. Some are demographic: old patients, male patients, those with systemic sclerosis, those with some mutations in bone morphogenic protein receptor 2 had worse prognosis. Those with advanced heart failure or in NIA class or WH class 3 or 4, those with 6-minute walk test less than 440 meter in adult, those with elevated natriuretic peptide, serum creatinine, total bilirubin, sodium, low sodium or elevated cardiac troponin do have worse prognosis. Echocardiography play an important role in risk stratification, especially the presence of dilated right atrium, the presence of pericardial effusion, the impairment of the RV function, and CMR can provide more accurate data regarding all these categories. From the hemodynamic point of view, the presence of elevated right atrial pressure and low cardiac output index are very major important prognostic factors in patients with pulmonary arterial hypertension. On the other hand, pulmonary artery pressure has no role in risk stratifications. Finally, any hospitalization in the last 6 months was proved in many studies to be a predictor for worse outcome. We have many scores, we have many tools. However, we used the score presented by the European Society of Cardiology, in which patients can be divided into low risk with mortality less than 5% per year, and the high risk with mortality more than 10%. And we have 9 categories that can be used to categorize our population. We have some methods to use this score. We can use 1 point for the low risk, 2 points for the intermediate risk, 3 points for the high risk. Then the risk score is the sum of the columns of the grade divided by the total number of the variable used. And we can do serial follow-up for our patient using this score. To conclude, a systematic approach is essential for proper diagnosis and follow-up and risk stratification of pulmonary hypertension patients. This will consider the patient characteristics, the pulmonary hypertension phenotypes, as well as the risk factors. Echocardiography is not a diagnostic method. It is a good screening tool. VQ scan is the first modality to diagnose CTAF. Right heart catheterization is important to confirm the diagnosis and to do phenotyping and to do the risk stratification and to follow up. And finally, all of these steps should be done in centers with high experience in the diagnosis and management of pulmonary hypertension. Thank you for your attention.
Thank you, Dr.
very much,
Karim
Dr. Karim, for this elegant presentation. Okay, go ahead, Dr. Reed.
Next speaker is Dr. Sudarshan Rajagopal, and his presentation is titled Updating the Management of Pulmonary Hypertension. Dr. Rajagopal?
Thank you, Dr. Buskirk, and thank you and Dr. Magdi and the organizers for the opportunity to present here today. I'm just loading up my screen here. Okay. So I have to also thank Dr. Karim with a very comprehensive view of pulmonary hypertension that makes my job a lot easier. So I'm just going to focus on the management of pulmonary hypertension, just my disclosures. So as Dr. Karim mentioned, pulmonary hypertension, you should think of it as a syndrome. It's really a heterogeneous group of diseases that all share the fact that the mean PA pressure is greater than 20. And for pulmonary arterial hypertension, we also include the PVRs greater than or equal to 3 Woods units with a wedge less than or equal to 15. Now, of course, there are many causes, and this is the basis for our clinical classification of pulmonary hypertension. Pulmonary arterial hypertension, where the disease is primarily in the arterioles. Left heart failure, where you have pulmonary venous hypertension. In lung disease, where you have damage to the lung parenchyma, so you start losing these blood vessels. In chronic pulmonary embolism, where you have blood clots that block the pulmonary arteries, and then miscellaneous diseases like sarcoidosis and sickle cell disease. But it's important to remember that patients now referred to us with PH are older, they're sicker, they have multiple comorbidities. It's much more common for us to see a patient who has elements of groups 1, 2, and 3, and we're left in a situation where it can be unclear as to what to do. So the treatment of PH really depends on how you define the patient falling into within these groups. So as Dr. Karim showed, vasoreactivity is sort of the first step in determining how you treat a patient. After a right heart cath, if they're vasoreactive, they get a calcium channel blocker. And we know from, this is the French data, but from data from Stuart Rich before that, that patients who are vasoreactive will usually be long-term responders with an excellent long-term response just to a calcium channel blocker. So what about patients who aren't vasodilator responsive? That's around 95 to 98% of those patients who have PAH. Well, we have 3 different pathways that we target with 4 different classes of medications. One here, we have the endothelin receptors. They're expressed on smooth muscle cells in the pulmonary arterioles. When they're activated, we have vasoconstriction and proliferation. So we treat these, we treat patients with endothelin receptor antagonists, or ERAs for short. Conversely, we also have prostacyclin receptors on smooth muscle cells. They promote vasodilation and are antiproliferative. So we treat with agonists that activate these receptors, and these are the prostacyclin receptor agonists. And then lastly, we have the nitric oxide signaling pathway that we all know is very important for endothelial function and health. And in general, this leads to the formation of cyclic GMP by soluble guanylate cyclase, activates things like protein kinase G. So we can either inhibit the degradation of cyclic GMP by phosphodiesterase 5 using phosphodiesterase 5 inhibitors, or we can directly stimulate the activity of guanylate cyclase to increase cyclic GMP levels using soluble guanylate cyclase stimulators. Now we might be seeing this in the heart failure space as well with vericiguat. So what are the drugs that we use? For the ERAs, bosentan was the oldest one. It requires monthly LFT monitoring, so it's not as due to the risk of hepatotoxicity, so not as commonly used today. And then ambrisentan and macitentan. For the PDE5 inhibitors, we have sildenafil and tadalafil. The SGC stimulators, we have riociguat. It's important to remember that an SGC stimulator can't be combined with a PDE5 inhibitor as it can cause life-threatening hypotension. And then we have the prostacyclin agonists, and we have multiple forms here. For IV forms, and this is given through a Hickman catheter 24/7, you have epoprostenol and treprostinil. Treprostinil also comes in subcutaneous pump, in inhaled form, and oral as well. Selexipag is another oral formulation, and then there's also inhaled iloprost. So how do we use all these drugs? So essentially, it depends on that risk assessment, as Dr. Karim showed earlier. For your highest risk patients, you are going to start them on combination therapy, and that will include a parenteral prostacyclin. And if your patient is functional class 4, and if we look at the guidelines, IV epoprostenol is the prostacyclin of choice, the only drug that's actually been shown to improve mortality, although we believe that all the drugs improve mortality. If your patient is low or intermediate risk, the vast majority of patients start on initial oral combination therapy. This is typically with a PDE5 inhibitor and an ERA. For some patients who are very low risk or might have mixed disease and you're not sure, you can try initial monotherapy. But then again, we go based on this risk assessment. After 3 to 6 months of treatment, is our patient still intermediate or high risk? In that situation, you end up on triple sequential combination therapy where you're hitting all 3 pathways. If they're low risk, then you've met your goal. Our goal here is really achieving low risk status. Now, for that patient who's on triple sequential combination therapy and they're still in intermediate high risk, then we have to think about therapies such as lung transplantation. Why do we do upfront combination therapy in our PAH patients? It was based primarily on this AMBITION trial that was published in 2015. And essentially it showed that combination therapy upfront after diagnosis with a PDE5 plus an ERA was better than treatment with a PDE5 alone, inhibitor alone, or an ERA alone. And that's our approach. How do we, our low risk status, as Dr. Karim showed the same slide here, we look at multiple parameters. Sometimes you can look at these and have a gestalt. There are risk scores though. There's a REVEAL risk score that's available online. It's a bit of a pain to calculate, but they are calculators for that. If you look at the French and German guidelines, they recommend looking at 6-minute walk distance greater than 440, a functional class 1 and 2 being low risk, having a normal NT-proBNP, and then having normal hemodynamics. What other therapies do we give our patients? Obviously, we need to keep them euvolemic with loop diuretics and aldosterone antagonists. Now, historically, there was a role for warfarin for idiopathic pulmonary arterial hypertension with a target INR of 1.5 to 2.5, but newer data really suggests a lack of benefit and potential harm, especially in patients who have scleroderma. They can have GI AVMs. Very little data to support the use of digoxin, really no data to suggest the use of sort of heart failure GDMT, although you would think that an SGLT2 inhibitor would work since it works pretty much with every other disease we've tested them in. Okay, so that covers very briefly group 1 PH. How about group 2? This is due to left heart disease. And really the focus is the treatment of the underlying heart disease. And it's very common, I think, frequently when you see, it's almost a reflex, like the oculostenotic reflex on a cath. Sometimes when you see that echo and you see a high RVSP, some people think, well, maybe I should just give them a PDE5 inhibitor. This data, there's newer data that gives us pause. Dr. Karim also showed this hemodynamic classification sort of for group 2 PH. You can either have folks who have isolated post-capillary PH. So these folks you're never going to treat with a PAH-specific therapy because their PVR is normal. Really, the issue is with the left side of the heart. But what do you do with these combined pre- and post-capillary PH patients, right? They have a high PVR. Sometimes you look at other things like the transpulmonary gradient or the diastolic pulmonary gradient, and maybe they also have some degree of right heart failure. There's a recently done trial from Spain called the CIEVAC trial. So these are patients who had corrected valvular disease, left-sided valvular disease with residual PH. Sometimes, I'm sure you've all seen patients who had mitral stenosis, had severe PH. They get their valve, the vast majority of those patients improve significantly and their pH goes away. There'll always be a few of these patients who have some residual pH. And sometimes we'll try them on a therapy. Well, this just used sildenafil in these patients, and it actually showed worsening in these types of patients. Now, it was groups of both aortic valve disease and mitral valve disease. But you can see just looking at the risk of hospitalization was actually higher in the sildenafil group than placebo. This trial actually changed my practice. I tended to, use sildenafil in these types of patients, and now I don't. So really, I take a look at the whole patient. If their major issue is right heart failure, then I'll think about treating them with a pH-specific therapy. Otherwise, I don't. How about group 3 pulmonary hypertension due to lung disease? So obviously, we focus on treating their underlying lung disease. Of course, all the treatments are pretty poor until the development of these antifibrotics for idiopathic pulmonary fibrosis. But we really have reached a new age here. This is really important data, and it's in revision at a high-impact journal, where inhaled treprostinil has been shown to be beneficial in the treatment of group 3 pulmonary hypertension in idiopathic interstitial pneumonias. The benefit was primarily seen in the IPF subgroup, less so in the combined pulmonary fibrosis and emphysema subgroup. But you can see here, this was a 6-minute walk distance based trial. There was a significant improvement in 6-minute walk distance in the group that was given inhaled treprostinil with no safety signal at all. So suggesting that it's very well tolerated by these patients who are in general very sick. This is not true of other pH-specific therapies. This is data from from riociguat in idiopathic interstitial pneumonias. No difference here in terms of clinical worsening. Actually, the trial was stopped early due to increased mortality in the riociguat arm. So this does not hold for all pH-specific therapies. Really, we just know for inhaled prostacyclin. How about group 4 pH, CTEPH? Here we have multiple options for therapy, and it really requires a team approach at an expert center. You can think about surgery or interventions. We have medical therapies as well. And actually, all of them have some good data behind them. The gold standard is pulmonary thromboendarterectomy, or also known pulmonary endarterectomy. I never call it that because it's called PEA, and I always think about pulseless electrical activity, so I still call it PTE. But this is really the gold standard treatment where you have an expert surgeon going in there and they're roto-rootering out this chronic blood clot. It's important to remember this is not an acute blood clot, right? These are patients who have been on anticoagulation for at least 3 months after diagnosis. So you don't go in there and see a platelet-rich, red blood cell-rich clot. Instead, this is scar tissue throughout the pulmonary vasculature. And this is how it looks when it's removed by a surgeon, right? So you can imagine this is a patient who's got proximal disease, but it extends all the way into the segments here. And this is the gold standard for treatment. If someone's a surgical candidate, they should get surgery. But we now have other options for folks who are either not surgical candidates or who have more distal disease, that is primarily segmental or subsegmental disease, with balloon pulmonary angioplasty. This was originally developed at Boston, but really has been perfected by the groups in Japan, including by Dr. Matsubara's group. And you can see here these webs and other lesions that are in the pulmonary vasculature can just be opened up with these non-compliant balloons, and you can get significant improvements in hemodynamics. We also have a role for medical therapy for patients who aren't surgical candidates. Riociguat is the only FDA-approved drug for the treatment of CTEPH. You can see here, compared to placebo, a significant improvement in 6-minute walk distance. But there is data for off-label use of other therapies, such as subcu treprostinil, shown here. This is work from Irene Lang's group, as well as macitentan. So essentially, there's data showing you could target all 3 pathways and that they could have some benefit in the treatment of CTEPH. That is because CTEPH, in addition to the proximal blockages, is also associated with the small vessel vasculopathy that is very similar to pulmonary arterial hypertension. So it is a very similar disease from that perspective. And how about for our group 5 PH patients? Again, this is a real grab bag of diseases, right? So in the US, and especially in the South, we see a lot of sarcoidosis-associated pulmonary hypertension, and there is data, all retrospective, uncontrolled data out there that suggests a benefit of pH therapies, and we use it in a number of patients with sarcoidosis-associated pH. Sickle cell disease, there's actually increased risk of pain crises with sildenafil in pH. Really, you have to focus on treating their underlying sickle cell disease aggressively and then seeing whether they still have any residual pH afterwards. And of course, the other large group is end-stage renal disease or chronic kidney disease. Very little data in that group to suggest a role for therapies. So to summarize, really treatment of pH is guided by the specific pH group. The most important thing here is diagnosis. It's really critical. And the current approach for treatment of PAH, that is group 1 pulmonary hypertension, focuses on the use of upfront combination therapy and really the achievement of low risk status. Our major challenges include the treatment of non-group 1 PH. I think our heart failure colleagues probably feel this the most. And then also in the management of patients who cross pH groups. A lot of our clinics are full of these patients who are older in age and they're group 1, 2, and 3, and maybe 4 and 5 thrown in. And it's very challenging to know how to treat these patients. All right. Thank you.
Thank you, Dr. Rajagopal, for that very nice presentation, along with Dr. Karim Saeed. Now we're opening our session for discussion. I'm going to pose the first question of the variation in the diagnostic criteria for PAH in your presentations. I am aware that in 2008, the World Symposium changed the diagnostic criteria from mean PA pressure of 25 all the way down to 20, which actually creates a lot of question mark in heart failure doctors like myself, because whenever we do a right heart cath in most of our heart failure patients, invariably we will see a mean PA pressure over 20. And thus suddenly the diagnosis of PH has now broadened to almost everybody. So comments on that. And I do realize normal patients or normal population used to be a different phenotype. Now we have obesity, CKD, elderly population, stiff ventricles. Tell me how oversensitive and or less specific this threshold is. So we'll start with you, Dr. Karim Saeed, and then maybe I'll ask Dr. Rajagopal to talk about the positives and negatives changing that threshold.
Okay, of course, this is a very controversial issue, even between the pulmonary hypertension experts themselves. However, some facts that may simplify our thinking about this change. First, this represents the norm, because if we calculate the mean plus the standard deviation of the pulmonary pressure among the normal population, we'll find 20 is the accurate norm for definition of pulmonary hypertension. The second, this definition, I am not sure it will have an impact on the threshold to start diagnosis till now, because in the majority of trials, still the standard, all the criterion was adopted, and it will be for some time. The third issue, this new threshold may
Dr. Karim, we lost you, I believe.
Okay. Can you hear me now? Yeah. I mean,
yes.
This new definition may provide some red flags among some populations, such as patients with systemic sclerosis, those patients with family history. And it was found that this new definition will not enlarge so much the pool of pulmonary hypertension patients eligible for pulmonary hypertension therapy. This is my thinking about this new 4 millimeter plus in the new definition.
Dr. Rajagopal, very briefly.
Sure. So I have to admit, I hate the change. So it is, I agree with Dr. Karim, it is scientifically based. This is work, sort of like a meta-analysis that was done to show that mean PA pressure normal is 14 plus or minus 3 standard deviation. So that makes your cutoff 20, right? Okay. And then there was data from the VA showing that patients who have a mean PA pressure greater than 20, that's when you start seeing increased mortality. But it's really, I mean, that's really just a marker of severe heart disease and severe lung disease. And obviously those patients are going to do poorly. There is still a PVR cutoff for the PAH group. So I don't think it'll bring in a lot of people. We used to have this category we called borderline PH, which would be, 21 to 25. And we're never sure what to do with people. Now we're just still not sure what to do with them as well. And then the other issue is that that definition for sort of the normals was based on a young population. The average age of people in the studies in their 30s and 40s. And we're seeing people in their 60s and 70s. Their average mean PA pressure for a normal patient in their 60s and 70s is not 14. I think we run into this issue all the time. So for me, I just find it problematic because there are more referrals for, that are sort of unnecessary. Someone freaks out and they're told they have pulmonary hypertension. They do a Google search and they think they're going to die. And it's just, they just change the criteria. So it's got pluses and minuses.
Thank you.
Can I ask question? Yeah, I'd like to ask question for Dr. Karim, Dr. Sudarshan, regarding the importance of exercise-induced pulmonary hypertension in patients who are complaining of dyspnea on effort. Should be treated the same like patients who have pulmonary hypertension at rest? The second question regarding risk stratification. If we look for Swedish registry, French registry, or compare their underestimation, overestimation of the risk from one risk score to the other. So maybe clinical judgment looking for signs of RV failure and echo looking for RV function are good risk stratification quickly for patients presenting, especially if I'm seeing the patient for the first time. And is there a rule for genetic studies to be included in risk stratification for pulmonary hypertension?
Dr. Karim, do you want to start? Or
I will give a comment related to the exercise. Till now, there is no standard definition for exercise-induced pulmonary hypertension because we do not know the normal for the physiological increase in the pulmonary pressure during exercise. So exercise pulmonary hypertension may be used for the diagnosis of some patients with heart failure with preserved ejection fraction. It is a good criterion with increased tricuspid regurg velocity. However, I'm not sure this is applicable for patients with pulmonary hypertension, and I'm not aware of any trial that tailor the therapy based upon a change in the pulmonary pressure during exercise. So till now, it is an unexplored domain in the pulmonary hypertension. For the second question, yes, the genetic issues, the right ventricular imaging by the CMR are not well taken in the current scoring tool for the risk stratification of pulmonary hypertension. And I think this may improve the performance. Some mutation in the morphogenic protein receptor 2 do have a worse prognosis, and it was not accounted for during preparation of this analysis of registries in which those scores were derived. So, Dr.
Hello.
Sure.
Dr. would you like to add something?
Sure. I'll just say for exercise pH, I mean, it used to be in the guidelines, right? Sort of with exercise, if the mean PA pressure goes above 30. Of course, now we know that a lot of that can be driven by exercise-induced HFpEF. So with, I think, the broader availability of invasive cardiopulmonary exercise testing, so I think that's the only way you can diagnose it. So you have to do a full right heart cath with a metabolic cart, and so you can calculate the all the parameters with exercise. You can get an exercise wedge, cardiac output, mean PA pressure, and everything. And very nice work from Greg Lewis's group and Robert Nai and Barry Borlaug and others. They've shown, I think, very nicely that there are people who do have this. Aaron Waxman, I should say, has got the most data with this. And I think it is reasonable to treat those patients if you can show their PVR shoots up with exercise and if their wedge stays below 25 with exercise. And I think there's better data for that now. There's that whole relationship, the delta P over delta CO of 3. When you map out mean PA pressure versus cardiac output. With regards to risk assessment, I agree exactly with Dr. Karim. Those risk tools, because they're designed for research purposes, really, so you could apply it across a registry, it doesn't include things like imaging where you can have a lot of operator-dependent analysis of, how someone's right ventricle looks, for example. I mean, if someone has a normal right ventricle and they have a low walk distance, they're not limited by pH. I think we'd all agree on that, right? Especially scleroderma patients who have a lot of reasons to be limited. So you can come up with different approaches for assessing risk. You don't have to necessarily follow that. And I agree with Dr. Karim on the BMPR2 definitely is associated with worse outcomes. And we don't have enough data, though, in general.
Do you all give a fluid challenge for those who may be masked for the post-capillary with the HFpEF-like, symptoms, but let's assume that their, initial wedge in the cath lab was normal. And yes, with the exercise, you could unmask it, but some do the fluid challenge. Do either of you do that?
We don't at ours, but it's reasonable. Like 500 cc, Vanderbilt has good data with that. You could just do a leg raise is also reasonable. We prefer exercise if we can do it.
Yes, we do this fluid challenge because we do not have an ergometer in our cath lab. So we do the fluid challenge.
I have a question, please. Yes, it's a question for both speakers. Thank you for both of them for this nice review. Now, with the COVID era, almost more than a year now, should we expect an increase in the pulmonary hypertension disease? And any feedback for both speakers from Egypt as well as from USA? And it's a question open to everybody. And the second question is, shall we eventually have a preventive role of the long-term oral anticoagulation in the post-COVID disease as a prevention for pulmonary hypertension? I don't know if there is enough feedback for all this disease for the last year, but I would like to have the experience and the opinion of both speakers, please.
Sure, I can start. I'll say, COVID definitely seems to have a higher increase of PE and VTE in general compared to typical ARDS. I think there's nice data from Eric Klock's group that has shown that, and maybe it's around 5% to risk of VTE in those patients. If you think about 2% of patients with acute PE go on to develop CTEPH, that could be a lot of patients who end up developing CTEPH. I think there are a number of clinical trials that are looking at that question, the role of anticoagulation, more aggressive anticoagulation, long-term anticoagulation in these types of patients to see. And I'm sure we'll also see a lot of group 3 pH too from folks who've had just damage to their lung parenchyma and developed pH from that standpoint.
Maybe we can have the opinion of Dr. Saeed, of Dr. Karim.
I agree with Dr. Sadar Shah, and I'm aware of some data coming from observational studies reviewed by the BVR showing that increased risk or increased rates of pulmonary hypertension in some population with severe COVID after recovery. They reported some increased prevalence of pulmonary hypertension may be related to many mechanisms, some related to the coagulopathies or the remodeling of the pulmonary arterial trees or the endothelitis known to occur in those populations. However, I think this is very early to have a conclusion related to the mechanistic link between the COVID and the development of pulmonary hypertension.
Yeah, I wanted to specify, as we know now, we're classifying the COVID as mild, moderate, or severe. You specified it, Dr. Karim, that in severe. Now, the question is mainly in mild to moderate, and I guess everybody is receiving questions from all our patients. Shall we take aspirin? Shall we take oral anticoagulation as a prevention? So I don't know. I guess there is no data yet.
There is no data, Dr. Kiwan, and I will provide some perspective. I was the issue editor in the Circulation Journal looking at all the COVID-19 articles and still continue to do so. Currently, the practice is for those hospitalized patients, especially with elevated D-dimer, there is a practice trend to use anticoagulation. Of course, those that are with, ACF-like presentation is also having the antiplatelet agents on board. Now, the other question that you posed, mild to moderate at home, what do we do? We're not doing the biomarker profiling of these patients, and they are, unless they're hypoxic, they're not in the hospital. Most of these patients are at home. And now we have very, a few studies looking at the long-term effects, as you have heard about the MRI studies. One MRI study from Germany in 100 patients demonstrating about 67% of the patients having MRI findings of either wall edema or late gadolinium enhancement. RV enlargement, which may imply chronic pulmonary hypertension, was seen in some, but the majority was wall edema and LGE. An interesting study from Israel, 100 consecutive patients hospitalized. Within 24 hours, they looked at the ventricle, and these were not shock patients. 2/3 had RV dysfunction. This could be from hypoxia or from the pulmonary circulature being stressed. Postmortem studies right now show microangiopathic clots, even those individuals who are not known to have classic PE and other, thromboembolic events. So postmortem, there appears to be endotheliolitis involving both the arterial as well as the venal system with microthrombi, even in individuals not known phenotypically having cardiac involvement and also having predominantly ARDS. So what is going to be the outcome on the pulmonary circulature and long-term is to be seen. There was one echo study very recently in a rehab symposium showing that 2/3 of the cases had HFpEF-like features, predominantly by diastology, diagnosed in individuals who had recovered from COVID at home. And then we also heard about the athletes from Ohio State demonstrating a significant proportion having MRI, again, wall, the T1, T2 image, and then the LGE findings. The long-term Doppler studies, I think, are going to be quite helpful. They're being conducted right now, as well as the biomarkers, but we're just at the beginning of this, and nobody knows whether to anticoagulate them as an outpatient. It's not being commonly done, though.
So it's not scientifically based, actually proven or evidence-based.
We don't know
so
yet.
We cannot take the risk of giving them anticoagulation blindly, the new oral anticoagulation blindly at home. You think, my final question, you think that aspirin may prevent, even if it's not proven yet, a small dose of aspirin?
I will ask Dr. Rajagopal to make the first few comments, and then maybe Dr. Said, and then I'll also chime in.
Thank you.
This is a data-free zone. So,
Dr. Said?
It's the same. I don't have any idea or data about this.
Thank you very much. Thank you.
There are some experimental studies showing that the platelet aggregation is also abnormal. Yes, I mean, we already know the vessel wall as well as, I'm sure, the whole inflammatory cascade as well as the platelets are involved. But the safety, what's going to happen to the prostacyclin and the rest, and whether the vasodilatory versus the antiplatelet effects are going to be more beneficial than the potential risk and bleeding and so forth are to be determined. We don't know, Dr. Kiwan.
Thank you very much. Thank you.
Okay, I think no more questions, or?
I was going to just ask if we have time. Do we have time, Dr. Magdi? I'm trying to look at the original schedule.
I think we finished this session, and then the closing remarks by Professor Sobhi and Professor Debti now. Okay. Yeah. So okay. I'd like to thank Professor Pekin for excellent chairing of this session. And this was a great session because it provided us with a roadmap for pulmonary hypertension regarding classification, diagnostic imaging modalities, risk stratification, and the different therapeutic options for pulmonary hypertension. So it was a great session and a great discussion. Professor Sobhi, Professor Debti.
Okay.
Thank you so much. This was a great session. I'll echo that. So I want to thank Bikram and Magdi for that last session. I want to thank Dr. Saeed as well as Dr. Rajagopal for a great talk. Previous to that, we had some great talks about stable coronary disease. So I want to thank Dr. Soliman, Dr. Kurdi, Dr. Zayada. And then I want to thank my co-chair, Dr. Kiman. And here we have Dr. Al-Mawardi. We missed you earlier. And Dr. Sobi. And so thanks to everybody for joining us for our fourth Middle East webinar. This is a series of 4. And again, I think Dr. Sobi mentioned at the onset that we will be having hopefully our live Middle East conference, which will be in October 14th and 15th in Cairo. Dr. Zayadi will be taking over as the co-chair for the Middle East conference from the ACC perspective as I step down and go into my presidency role. So I want to thank all of you for your attendance, and it's just so nice to see all my friends, even though it's only on Zoom. I'll hand it over to Dr. Sobi.
Okay, Deputy, thank you very much. I think today it's a great webinar for the end of this webinar. So actually, the first chronic stable angina. Yes, Dr. Ramzi Mawardi was joining us, but it was difficult technically. Thank you very much, Dr. Kurdi, Dr. Haytham, and also Dr. Mawardi is joining us. And then the second, pulmonary hypertension. Usually, this is the third. We made also the CVREP waves for the pulmonary hypertension. Karim was joining us. I think it comes to stay because it was neglected before, but because of these drugs, new drugs, I think, and we need now this will be opened, and also the techniques. So pulmonary hypertension now is an issue like the chronic stable angina and ischemic heart disease, and even the heart failure now association. Pulmonary hypertension itself very important. Let's go for the records. I'm just waiting for the records for this meeting. Actually, it's 230. If you don't allow me to say that, because I don't type it, from Egypt, Saudi Arabia, Emirates, India, Oman, Lebanon, Nigeria, Qatar, USA, Iraq, Iran, Yemen, Canada, UK, Jordan, Kuwait, Malaysia, Pakistan, Rwanda, Syria, Tanzania, and South Africa. This is great. Actually, I know this number is less than before, but because maybe the timing problem, which we have it, but actually we succeeded to finish this. Thank you very, very much for this. If you allow me, after this, I can just have a short talk about Odyssey trial from the last ACC, if you don't mind this, okay? I will share the screen.
Mohammed, I do have to leave, so I'm going to say goodbye.
Okay, thank you, Deputy. If
thank
you
you.
Okay, but just take 10 minutes, and then we need your opinion. Thank you, Deputy, for
bye-bye.
Bye-bye.
Bye.
Okay.
Bye.
Sorry. I'm sorry, this one is not the one I have. Odyssey. Okay. Yes. Okay. If you allow me, this is the late-breaking clinical trials on data in ACC 2020. This slide shows all of us know that the guideline managed dyslipidemia, and the targets from the very high risk to be 55. The high risk is 70, moderate 100, and low 106. So extended changes between 3 years, between 70 and 55 millimeter mercury. And also the management differs from the risk of the fatal cardiovascular disease 10 years between the regions, the high-risk regions and low-risk regions. And this is evidence that some countries have a cardiovascular mortality rate. Egypt is one of them. The high-risk chart may be underestimating risks. So the guideline, the managed dyslipidemia, is saying that with very high risk, we reach 55, and it's not or, and LD reduction of more than 50. It's 1C in the primary prevention, also the same, 55 and more than 50. It's 1C in primary prevention of individual familial hyperlipidemia, very high risk, reaching only 55. Regarding, this is very new from the guidelines, that we should reach 40 if you have a second vascular event, but not necessarily the same type as the first event, this 2BB. How to reach this? Statins, if failed islamide, if failed PCS9, this is in different classes. And also the intensity of the lipid lowering with the moderate intensity or high intensity islamide, PCS9 with the islamide, the high intensity is 85%. So this percent of reduction in LDL together with the baseline is called absolute reduction, and the relative risk reduction with the baseline risk means absolute risk reduction. So the recommendation is to make the lipid level every 4 to 6 weeks, and also LD goal it should be in 4 to 6 weeks 1B. For those with ACS, and this is important now, where LDL cholesterol not at goal, at maximally tolerated statins, and add islamide, adding PCS9 after the event, if possible, which is new, during hospitalization ACS event in class 2AC. Let's go to what happened in the last, the Odyssey. Remember that Odyssey outcomes, it's post-ACS patients, at least one lipid, alirocumab twice, a placebo, the high-intensity maximum tolerated statins. The target range leads to 25, 50, and acceptable range between 15 and 25. Below 15 is below targets not allowed. The efficacy, primary efficacy with the MACE is 2% absolute risk reduction, with the relative risk reduction 15%, and also all-cause death is 15%. So the achievement of the new European dyslipidemia guidelines, this insight from the Odyssey outcomes in the last ECC in Chicago, 2020, actually the background that and this guideline, how to reach it out, Odyssey outcome, that percentage of patients showing who achieved LDL less than 55, at least one measurement according at the base LDL level. So out of these patients treated with alirocumab, 95% achieved LDL less than 1.4 millimole, at least one post-baseline measurements compared with 17% placebo arm. And also, of patients with at least one prior ischemic cardiovascular event, addition to index ACS, 84% assigned with achieving with the alirocumab LDL less than 1 millimole at any time after baseline compared to 3.7 with placebo. So the results of this study is among patients not previously treated with semaglutide, projecting 18% reduction in LDL from baseline to simulate the addition of this combination. 10% of patients would have met the LDL goal less than 55, and none would have met the goal of 40 at baseline prior to treatment. None reaching 40, and only 10% reaching 55. The second study in 2020 is called Odyssey Uprise. Its efficacy and safety of alirocumab in real life setting in patients with or without familial hypercholesterolemia. The background that the inadequate control is found in even non-familial or familial or homozygous. Odyssey Uprise is a prospective real-life study in Europe and Canada to obtain safety and efficacy data of alirocumab and high cardiovascular risk with patients with or without homozygous epidemic with severe hypercholesterolemia inadequately treated with a medical treatment statin with other lower living drugs. So the methods in the single-arm phase 3B study, open label treatment of 12 weeks to less than 30 months. All the patients receive subcutaneous alirocumab twice every 2 weeks with dose adjustment according to the physician's judgment. Primary endpoints, assessment of the safety parameters, including adverse events. Secondary efficacy, at 12 weeks, proportion of patients achieved LDL less than 70 and more than 50% reduction from baseline and percentage change from baseline LDL cholesterol, other lipid parameters. Safety and efficacy parameters, descriptive the statistics for the overall population according to hyperlipidemia status. So what are the results? Overview, at only 7.8% treatment adverse events, It's called nasopharyngitis, myalgia 7%, headache 6%, and influenza, flu or like influenza is 5.3%. The percent change of baseline at week 12 from the LDL, showing LDL decreasing by 55% either in overall and homozygous, non-homozygous, or non-familial hyperlipidemia, with no change in in triglycerides, but also reduction of non-HDL by 46%, and some rise of the HDL. The reduction occurs, a reduction here, as you can see from the 4th week, and from baseline to week to marked reduction, and then sustained up to 120 week. The conclusion of this, that for patients with hypercholesterolemia and high cardiovascular risk, dulcomab treatment generally well tolerated and resulted in clinically significant reaction at real-time, real-life setting. Thank you very much. I need just discussion regarding the Odyssey trials and what you have in real life in different areas. We have United States, we have Egypt, we have Lebanon, and we have Saudi Arabia. Can we start with Dr. Ramzi Al-Mawardi? What's your opinion?
Yes. Hello. Good evening, Dr. Sabhi. I enjoyed your presentation. I think in patients with acute coronary syndrome, we have to be more aggressive in treating hypercholesterolemia. The Odyssey trial, as we all know, decreased the cardiovascular events 15% at 3 years. But strangely enough, there was no significant reduction in cardiovascular death, although MI decreased 14%, stroke decreased 27%. Strangely enough, in both trials, the Odyssey trial and the trial before, the Fourier trial, 3 to 5% of patients in these two trials were receiving ezetimibe. They were also taking high-intensity statins, of course, 92% in the Odyssey and 70% in the Fourier. So as we go back to the guidelines and the application of the guidelines, we say those not at target with maximum tolerable doses of statins, you go to ezetimibe. And ezetimibe is not reaching the target of goal, then you go to the monoclonal antibiotic therapy. So it's very strange enough why in these two trials, the ezetimibe wasn't given in most of the patients. So this is a defect, I think, in the design of the trial. These patients should have had more ezetimibe. Maybe the results would have been better. We don't know. We know that aggressive treatment with these drugs, whether it's the high tolerable dose of statin with ezetimibe and the monoclonal antibiotic therapy, we should know that even going down to 20 and 30 milligram LDL has no fear, and the efficacy and safety is there. There is no increase in hemorrhagic stroke. And if we go back to the IMPROVE trial, we find the same results. Combination of a statin with ezetimibe in acute coronary syndrome patients, there was no problem of the safety going down to 20 or 30 milligram LDL. Okay.
Answer. Thank you very much for your comments regarding why not ezetimibe. I think the ezetimibe was questionable because, as you know, the IMPROVE trial stopped and then regained. So at that time, because of this changes in the combination therapies, ezetimibe, I think both study Fourier and Odyssey ignore ezetimibe as no importance. And during this trial, during this study, ezetimibe improved start by only 8%. So maybe, but I'm not saying the guide. So the guidelines say that first statins and then combination and then PCSK9, but only for 6 weeks. So this be allowed to.
I have a question for you, Dr. Stop.
But
very interesting presentation. I'm asking about in-hospital PCSK9 alirocumab for patients post-ACS. We need to consider in-hospital before discharge PCSK9.
Regarding the last guideline, this class 2B, yes, we can, during the index hospitalization, in the second, particularly if it is second event, you should start PCS9 in the hospitals. If it is a first event, it is questionable. It's not class 1A. So you start high intensity statin, then combination after 4-6 weeks. If no response, PCS9. But the only, I think, indication to my mind is if you have a second event, you will not reach 40. How can you reach it? I think in the index population, this is supported by the European guidelines 2AB. Dr. Kordi.
I think the role of adding the PCSK9 inhibitors has been limited to high-risk population, and in particular, as you stated correctly, in patient who fails the intense statin therapy. I think the literature is very supportive for the addition of such therapy. I found difficulty on patients who's been on statin and other list of medications to add the additional injections when their LDL is like 1.8 or below, and then they come to your clinic and they are coming for a follow-up and they're stable on their medication. And I'm telling them, you need maybe to go lower and we need to add another one. I found that's a little bit of a difficult sell for a lot of our patients. And of course, especially the one who's actually not covered by insurance, where the cost is going to be a big burden. But yes, I think there's a space, I think, for high-risk population and people with recurrent events. I think that's where we should be utilizing the drug.
So let's to the United States, because they are embarrassed, I think. Pickman and Khalid Ziyada, how make it? If there's no problem with the price and you have indication in the United States, how a percentage of your patients are using PCS9? In our country, it's a small percent because of the cost. And particularly we make it for familial hyperlipidemia, for statin intolerance, and for secondary events, particularly ACC in the index population. How be the indication in the United States?
I can comment. Currently, the coverage is very limited. So the payers are not covering the PCSK9s in majority of the cases. It requires a lot of paperwork during a time of which most providers or the patients give up, and the out-of-pocket cost is truly quite a lot. So in the United States, cost is a major barrier. And insurance coverage, as I said, is very, very challenging. Beyond that, the comfort level of the physicians in prescribing this is not as much, and thus, even amongst those who could have been covered, we believe that the appropriate uptake of use of these agents is lower than the indicated population. Our highest risk populations are usually in the underserved areas where there's poverty, clustering of comorbidities, and those are the underrepresented minorities. Those are the ones that are not even being considered for these agents. So there's a huge disparity. The young individuals that are with repeated cardiovascular events, including women, including those with familial pattern and premature heart disease, who could have benefited for preventive, either secondary or even preventive strategies, are not getting these therapies. So the use is not as high as presumed in the United States either. There are best practices. There are certain centers who have expanded their ability to apply for the authorization and create a process with advanced practitioners, nurse practitioners, and PAs who do the paperwork. It's almost like a factory process line where this is done, and those practices actually are much more successful in prescribing and providing this care.
Dr. Khalid Ziyada, how do you do for the familial hyperlipidemia and those who have statin intolerance and those who have a secondary event? What's your advice?
So I totally agree with Baikam about the comment about, cost is still important in the U.S. It's not that easy to get insurance companies to agree. We have the assembly line, the factory that does this, and it runs through the specialty pharmacy. They have special process by which, you sign the order, and then a lot of people do a lot of things to try to get it done. But still, it is a problem. And For familial hypercholesterolemia, I think it's relatively easier to justify it because of the lack of efficacy with the statins or the inadequate efficacy. For other indications, it's a little tricky. You know, when you say statin intolerance, obviously people argue back and forth about this. You have to try something else. You have to try it for longer. You have to try a third age, et cetera, et cetera. So, you know, if you eventually get to like somebody who is intolerant to 3 or 4 agents, you probably will get it accepted and funded. But again, it is not straightforward. And I think the uptake is not going to improve unless the price is dramatically reduced.
Okay. Any questions from the? Okay.
It's almost like an appeals process in the United States. Yeah. You get rejected and you appeal it. Rejected, appeal it. After the third time, you will then get authorized.
So what you are going to say after inclisiran in the next year? It's just inclisiran, which is for the messenger RNA, so for Novartis drug, it will be more expensive. I think this will take very great effort to prove it in the markets.
So this is a difficult problem. I actually don't necessarily blame the pharmaceutical companies for this. I think that a lot of work goes into developing these things, and there's a lot of expense that goes into that. So I'm not blaming them for charging such a high cost, but at the same time, realistically speaking, if you're an insurance company, how can you cover this for hundreds of thousands or millions of people? You just can't. And so that's why they become so restrictive. So there needs to be some kind of compromise in which these things can make it to the public.
And most of the companies now make what's known as patient program. It will be 3 tablets.
Yeah. So that's a problem. I don't know about this one, but let me warn you about the patient program. So the patient program expires after a year. And then the patient comes back and says, you know, they didn't renew my prescription. I said, well, now we have to pay for it. And of course, most patients can't. So that's another problem.
Thank you. Any questions? Okay, I'd like thank you very much for all of you for attending the Wave 4 webinar, and I hope to we can make for you a new program for the next year. Khaled is the chairman of this international ACC Middle East, together with Dr. Magdi Al-Hamid and myself. I hope that we can make for you a good program and more attendee, physically and virtually as well. Thank you very much. Have a nice weekend. Bye-bye.
Thank you.
Thank you.
Thank you very much. Bye.
Bye.